It's 5 minutes past our scheduled time, so we'll get started and then we'll have other people join later. I can see names of all the attendees except one whose name comes up as Moto. I believe that's your phone. I request if you could just edit your name so that we can identify you. And while you do that, welcome all of you to the weekly Huddle session 47. We have been doing it weekly every Wednesday for kind of short of close to 10 months now. And what we typically do is we pick up a basic topic which is relevant to our daily clinical practice. And we engage in a casual interaction in terms of how we would have handled this particular situation, taking science background and practical issues into account, and share a more pragmatic version of what we would do to a particular patient or a particular scenario. Most of you are well aware of the format of the huddle. It is not a speaker and an audience model, rather an audience interaction where each one of us share our own thoughts. Today's topic is very relevant to the upcoming month of Ramadan, which starts today. So Ramadan Mubarak to all the attendees who do celebrate Ramadan. And the topic for today relates to the modifications that many patients often ask us before the Ramadan starts. So we could have done this session last week itself, but last week we had something more important to discuss, so might well today. So what I typically do is I start with a clinical case. I have my colleague, Dr. Praneeth, give his initial impression, and then we go down our attendees list and ask for their opinion. So Praneeth, this is a case scenario which I have already shared it in the chat box. It's a 60-year-old female. She had a past history of diabetes for the past 10 years. She's on insulin for about 2 years now. Her last A1C was about 7.5 and without any hypoglycemic episodes. She has been managing reasonably well. She has a chronic kidney disease with a baseline creatinine running somewhere around 2 to 2.5. Her most recent creatinine was 2.2. She had a lateral wall MI about 8 months ago, for which she underwent primary PCI, and her stay was otherwise uncomplicated, and her creatinine function did not deteriorate post myocardial infarction. She had preserved her left ventricular ejection fraction at that time, and she had been doing reasonably well. That was 8 months ago, and she's on routine medications, including dual antiplatelet, oral hypoglycemic agents, antihypertensive agents, and pretty typical. She comes here for a routine follow-up. She does not have any obvious symptoms. She's leading her life what you would expect to a 60-year-old female at home. She's a housewife. She does not work. She came to you with her routine checkup. Her vitals are okay. Her physical examination mostly is unremarkable. Her routine laboratories findings are also okay, except her CKD with her creatinine being around 2.2 this time as well. She asks you that she desires to fast for Ramadan, and we all know that the fasting is from morning till early evening, I would say. And that goes on for a month, today being the first day. And she asks your permission to see if she can fast safely. And secondly, is there any modifications to her medications, to her lifestyle, and to her diet that she needs to do? So Praneeth, your suggestions, I have divided into 5 questions. One, would you advise her not to fast at all? If you would advise her against, your rationale. What are the criteria typically that you use where you say fasting is okay in such patients? Any medication adjustments you do, any dietary advice that you give, and any behavioral advice you give. So Praneeth, you can take a few minutes to go through this, and then we will ask our audience for their interaction.
Yeah, good evening, everyone. So, being born and brought up in Hyderabad, Ramadan is something which is kind of special to almost everyone. Right? And so, you are encountered with Ramadan, and now being in profession, also have to answer the questions related to Ramadan, particularly the fasting. Most of the patients, they have their appointment fixed a bit early before Ramadan to get their questions answered because this is something which is quite important festival. So most of them they take it as a pride to fast and most of them would definitely want to fast. So my thought process is I'm a bit conservative, so I would encourage most of my patients to observe fasting. So I am a bit conservative in that regard. So this patient, the way I look at is 6 months post the acute coronary syndrome and relatively stable. No change of drugs, no episodes of any heart failure. Probably both CKD and the coronary artery disease seems to be in a stable fashion, and equally diabetes probably well controlled and stable. No frequent change of medications or anything. So for her, I would say yes, you can go for fasting. The things that I would ask her is to not to skip the medications at any cost. So the modifications is at if there are any medications which need to be taken in the afternoon, I would suggest them to take it either during before they go into the fast or after they break the fast in the late evening. So I would try to tell them that all these medications are supposed to be taken in the 24-hour period and the time frames which are convenient you try to take it. So I would try to review their medication list, any medications which are uh, 3 times a day or something which needs to be taken in the afternoon. I'll try to skip them into push them into twice daily thing, and I would try to prefer giving them longer acting drugs like beta blockers or other hypoglycemic agents or other things which can be reasonably manageable. And modifications and all again when they break fast or when they during the iftar when they want to break fast, I ask them again to pay attention to what they are eating and not to eat more than what it is required and try to have moderate quantities and be conservative in not to push their limits and it is okay not to push limits and once in a while if things become too hard to be okay and break the fast, try to observe in a day or two. If you are comfortable, try to continue the entire month and be flexible with yourself. 1 or 2 days if you are not able to keep the fast, it's okay to break. So this is what I would advise my patients.
Pranit, few follow-up questions, and then we will discuss with our attendees. One,
Sure.
uh, these patients, when they are on long-acting sorbitrates, like typically a GTN sorbitrate twice daily, which is given at, for our routine patients, we give it in the morning, and the
Hmm.
second dose we give it in early evening.
Yeah.
How do you handle sorbitrate dosing in these patients?
So I would try to prefer to give them a longer acting mononitrate formulation, which can act for about 12 hours. So that is one way of changing it. And if they are only want to take this thing, then I ask them to take it just before they go into the fast, and the second dose just after they break their fast.
Second question is, there are certain drugs you give it TID, you cannot change it to twice daily, or you prefer not to. Is there a way you handle? You give them early in when they break fast and then late at night, or you think those kind of regimens don't work? You keep it twice daily.
So as long as possible, you try to modify the regimen so that it is kind of okay where the pill burden is reduced. Try to make it combinations and so that the compliance will be better and try to um, skip some of the drugs which you do not think are much essential and try to make it as comfortable as it is for the patient so that they are not even risking their health and equally they are able to observe their religious fast. If some of the drugs are extremely important and there is a possibility that we are not able to stop this medication, like for some patients who are requiring multiple tablets for their management of diabetes and if we stop them, they go into uncontrolled diabetes and ketosis or whatnot, then I would suggest them that this is too risky, and then I would suggest them not to go for fast. So try to reduce your pill burden, make it twice daily regimen as much as you can. If still not possible, then suggest them not to fast.
And then last question, which I'm going to ask all my attendees is, patients who are on diuretic, how do you handle that?
Yeah. So this patient are those patients who require diuretics. So most of the patients depends on how much they are dependent on diuretics and what is their fluid status or the hydration status. Those patients who are dependent on diuretics for management of their volume status. So for them, I would suggest them not to fast because that fluid balance kind of gets disturbed. Those who are kind of SOS requirement of diuretics for managing their heart failure, if they are able to manage their fluid input output, and then for them I would be okay. And again, the same principle key, take it either before you go into the fast or after you break the fast. For those whom the modifying the dose of diuretics is tricky or challenging, or for who are kind of dependent, for them I would suggest them not to fast.
Perfect. Thank you so much, Praneeth. Let me go down the line and let me get some expertise first, then we'll go to general discussion. Vrinda is an endocrinologist. You all know her. Vrinda, this patient on insulin, and typically they are on some oral hypoglycemic as well. Walk us through how does Ramadan and these insulin and oral adjustments happen. One particular question that I have as you talk about is there a utility of switching their sulfonylurea to some other class of drug even when it is nicely under control? So Vrinda, take it.
Hi, good evening, everyone. So, so usually, like in practically speaking, if I get to see a diabetic patient, say at least a month before Ramadan starts, I think it gives us a lot of opportunity to titrate their medications, doses, to appropriate blood sugar control and talk about the risk of fasting, not fasting during this month. But let's say, keeping in mind the case that we have currently, so my take is that patients, elderly patients who have any other comorbidities, especially CKD, because that may increase the risk of developing hypoglycemia. um, I would try to talk to the patients, try to see where they are in terms of how eager they are to keep the fast. Usually, but like Dr. Praneeth said, this is something which is very close to their heart. So keeping in line with their wishes, if they really want to go for fast, then especially for patients like this case scenario where the patient is using insulin, I would be very mindful of what kind of insulin they are using, and then how we may taper it down to reduce the risk for both hypoglycemia during the day, and then the risk for also hyperglycemia that may be associated with overeating when they break their fast or during iftar. So it's important to analyze, like what medications, anti-hyperglycemics, are being given in the morning or being given at lunch, what are they taking at dinner time, and then how we need to actually titrate it for the month of Ramadan. So say for this patient, I would, if let's say this patient, commonly, like oftentimes in India we see patients using pre-mixed insulin. So if they are using pre-mixed
So
insulin and I
Vrinda,
have this.
let me just
Yes.
interrupt you. I'll tell you this patient's medication regimen. This patient takes glimepiride 1 mg twice daily,
Okay.
teneligliptin 20 milligrams once daily, and mixed hard insulin takes 22 in the morning and 16 in the evening. That is this patient's current regimen.
Okay. So, so I'll start out with insulin. So for pre-mixed insulin, as I was mentioning, a lot of people take it. I would see if there is an opportunity, if I say get to see them, like say a couple of weeks or 3 weeks before Ramadan starts, I'll see if they can be switched to long acting basal insulin. And then life is easy with using basal insulin, which can be given after iftar in the evening. And then a rapid acting, a short acting insulin, like switching them to say Novolog or Humalog, glulicine aspart, if that can be given as a rapid acting bolus just with the iftar, that can be taken up. But let's say for this patient, we don't have the opportunity to change the insulins in time. Then I would usually reduce the dose of the morning insulin, roughly say by about say 25 to 30%, and then like keep the evening dose the same, or maybe like have the option to increase it a little bit depending on the blood sugars. But I would specifically reduce the medication use in the morning. So for this patient, I would say I'll continue the premixed insulin, but reduce the dose. If this patient's A1C is 7.5, so I'm assuming she's not too bad in terms of glycemic control. So I'll reduce the morning medication dose by 25 to 30%, and then have these patients check their blood sugars. I usually will tell them as a homework for like first 2 days, check your blood sugars, say 2 to 3 times a day. And then I also tell them that, checking the blood sugars would not break their fast. So, check their blood sugars and, inform it to me so that we can better titrate the blood sugars. But coming to glimepiride, I'll usually stop the sulfonylureas for these patients. Even though, with the thought that longer acting sulfonylureas like glimepiride would be okay. But I think, especially given the risk of hypoglycemia during the day and these patients that are already taking insulin, so, the combination of sulfonylurea plus insulin would increase their risk of developing hypoglycemia. Plus, this patient has CKD. So I would cut down or stop the sulfonylurea in this case, essentially. DPP-4 inhibitors like Teniva, teneligliptin are usually safer for use. They are okay for me. I would switch their time. So I would usually ask them to take any other oral antihyperglycemic agent, be it metformin or teneligliptin in this case, to take it when they break their fast. So take it in the evening time, and don't take it in the morning.
Thank you, Vrinda. We will continue our discussion. May I invite Neha to give us some suggestions about dietary modifications in these patients. So let's say a patient like this comes to you in heart failure clinic, who is on insulin, who is on cardiac medications. The medications have been adjusted by the doctors. They particularly need your advice in terms of what kind of dietary modifications they can do with reference to Ramadan fasting. And Neha, how would you guide patients like this? Please unmute yourself first.
Good evening, all. So basically, first thing is like in our city, people they usually follow traditions and cultures when it comes to the month of Ramadan. Like they follow high carbohydrate diet. As a part of culture, they include all kinds of high carbohydrate foods in the diet. So first, awareness about the diet has to be given to the patient to make sure that they do not end up with hyperglycemia or episodes of hyperglycemia. So as the most immediate risk with fasting is potential for hypoglycemia in patients who are on anti-diabetic and especially on insulin. Episodes of dehydration can also be observed, such as nausea, dizziness. So therefore, first awareness about these things has to be given to the patients, and specifically people should understand the importance of healthy diet to be followed when they are observing the fast. So in order to that, they can include energy-rich foods in the diet before starting the fast, like they can include dry fruits in their diet. So people here, mostly they don't follow for this. So they go for like salty foods, masala items and all. So instructions about these foods to be avoided in the diet should be first given to the patient, and including more vegetables and high fiber foods should be told to the patient. And also I'll advise my patients to take 1 cup of curd before they observe the fast, so that it soothes the stomach and also help in good digestion. And after breaking the fast, because the people are following a long 14 hours fast continuously without water, so they end up with taking high carbohydrate drinks such as fruit juices, so that has to be avoided in the diet. So they need to know that taking plenty amount of fruit juices after breaking the fast might cause hypoglycemia. And also heart failure patients, they'll be having a restriction. So these things should be first instructed to the patient, so that later they do not end up with any complications. And also, if such case, like if any heart failure patient is observing fast with insulin, then they need to be under dietary supervision also for at least a week, so that we can understand like what dietary changes he is following in his diet, and how well he's doing with his diet. If any changes are there, or if any episodes of hyperglycemia are there, we can guide them and we can counsel them the right answer.
Thank you, Neha, for your suggestions. We will move forward. We have got Dr. Radha with us. Dr. Radha is a dietetics expert at AIG. She had joined us before in our previous huddle, sharing her expertise. Dr. Radha, we are talking about a 60-year-old female who has diabetes, heart disease, recent MI, and chronic kidney disease with a creatinine of 2.2. This patient is seeking to fast for Ramadan, and Dr. Praneeth, cardiologist, has cleared her for fasting. Now she comes to you for dietary advice. Neha has already given her suggestions. How would you take up this patient? What kind of suggestions you would give to this patient? Dr. Radha, if you could unmute yourself.
Yeah, thank you so much. And I'm really sorry to have been joining late in the discussion. I had a patient and I had to finish that patient review and then come into this program. Talking about Ramadan and somebody who has heart failure, type 2 diabetic, first thing is you have to categorize them along with your medical team, whether they are high risk or low risk patients, because these are the patients who are fasting, not risk of dehydration is there, and then could be hypoglycemia, could be hyperglycemia, depending on what kind of foods, what kind of medication that they are taking. So it depends on everything, that it is a teamwork that happens. First, review the medications and see if they are on insulin. Then of course there has to be a little bit of education that has to be done, that these patients have to be knowing about carb counting, because 1 unit of insulin is 15 grams of carbohydrate. So are they accommodating their food in such a way that they take complex carbohydrates, which will kind of adjust with the insulin? If it is in the morning, it has to be more complex carbohydrates, so that the morning the dawn eating, or before the dawn that they eat, should be with complex carbohydrates, so that they sustain the whole day. And then in the evening, they kind of break it with a mix of different kinds of carbohydrates, so that it sustains. And then the insulin change has to happen. What is the kind of insulin that they are taking, if they are? Because when you take 70-30, or when you take the long acting and the medium acting insulins, then you have to know how much to give carbohydrate, what kind of carbohydrates, what should be there. Or do we change them to 50-50, which is like a mix of both? And in hypoglycemia, to prevent hypoglycemia, what are the kind of foods that they take? Then to prevent dehydration, what are the kinds of fluid? Fruit juices is one of them that they may take, but then you have to look into the risk of dehydration for these patients, especially if they are on oral hypoglycemic drugs. Some of them do have this dehydration risk in them. So these are things as an overall approach you have to see. And if they are CKD, again, there are a list of foods which, if they are diagnosed as being CKD, there are a list of fruits and vegetables which they have to avoid. So within that list, the list becomes smaller and smaller with more number of diseases added to it. So within that, what can they do? Because the cardiologist has said yes for going in for the Ramadan fasting. So that's how it generally happens. But carb counting is the main thing that they have to learn. I really don't know whether I did justice to the answer.
So, Dr. Radha, I have a few follow-up questions to that. So carb counting, I remember talking to Vrinda early on, where it was pretty much standard when she was practicing in US. Coming back to India, it becomes a little bit difficult. In your opinion, or in your experience, how
Yes.
practical it is for patients to do carb counting in India? What percentage of your patients do carb counting who are on insulin? Give us a realistic picture that you see.
Yeah, exactly. I have around 5 to 8% of my diabetic patients wanting to know carb counting because they should be educated. They should be maintaining their glycemic levels and then take them to the higher level of carb counting. There is something called as a basic carb counting, and then there is an advanced carb counting. Basic carb counting is something that we can teach around 50 to 60% of the patients who come to us. It is just that I have to tell them the quantities of foods. Like, 2 slices of bread is equal to so many grams of rice. And then I can say you can change. This is basic. But then how to change? I have to give them pictorial. I have to give them in quantities. They should be willing to do it. But 100% is done by 5 to 6% of my patients. That's it. The rest don't do. But then, see, carb count in Ramadan, what is more important is I have to do the carb counting, not the patient. I have to say how many grams of carbohydrate have to be provided to this patient on so many units of insulin. So it's a homework for me. And then I kind of educate the patient on so much quantity of food you can have when you break your fast or when you kind of prepare in the morning before you start fasting. So that's how I have to prepare. So there are 2 sets of diets which I have to give, one for the morning, one for the night, and then during the night, what kind of fluids, how much fluids, so that he prevents dehydration.
Perfect. My follow-up question to you was actually on your last statement, and that is, so as a cardiologist, 2 things I want them to do, and if you could help us identify some of the objective pointers. The 2 things that I want is, I want them to eat complex carbs in the morning, and
Yes.
second, I want them to eat or consume things which is going to keep them hydrated for rest of the day. So I can only give them the theory behind it. If I tell them to eat complex carb, they can't go to a store and buy complex carb. They need to know what exactly to buy. So help us out in the morning food choices, A, for complex carb, and B, to keep them hydrated for the day.
Yeah. See, complex carbs in the morning, if they are eating roti, then yes, I tell them, go ahead, eat the roti, but in that, whether they can mix a little bit of soy flour and make the roti for themselves at home. So that's kind of, a mix of protein and complex carbohydrate. Wheat is a complex, whole wheat, for example. Or if they want to eat oats, yes, go ahead and eat oats. If they want to eat muesli, yes, go ahead and eat. Or I give them a choice that you can eat rice, no problem, but then eat lots of salad along with it. So, it's a mix. And then the glycemic index of the whole thing, this is another concept which we generally teach patients, is it's not about a single item and a glycemic index. It's about the whole meal glycemic index. Because that is what is more important than single foods that you take into consideration. So the glycemic index of the whole meal or the mixed meal drops down when you mix it with a protein and when you mix with vegetables and fruits. So that's how we teach them. Oil is another thing which you attach to your complex carbs, so the whole glycemic index falls down. Watermelon, they eat a lot of watermelon, but the glycemic load of watermelon is very high, though the index is very low. So I have to strike a balance on trying to give them something which has high glycemic index and low glycemic load along with watermelon. So that's a mix that again I have to do. So I have to give them choices of this kind. And then fluids, again, it's again a mix. I tell them to eat oranges, drink orange juice with pulp, fresh orange juice without sugar added, but not watermelon juice. I tell them to eat pomegranate seeds, but not pomegranate juice. So that is what I tell them to drink lassi, buttermilk, but not without salt if my patient is CKD again. So these are things that I keep. Once in a while, yes, coconut water is allowed. It's a taboo to say that, diabetics are not allowed with coconut water, but yes, they can go ahead and have coconut water. Dates are allowed, but not only just to break the fast, which they do eat. But then I tell them to eat more amount of more fibrous fruits, like, guavas, apples, pomegranates, papaya. Muskmelon is better than watermelon. So I tell them that you can eat watermelon, but mix it with something else which is more complex. So these are things that these choice, and I've told this in my meeting with all of you all before also, and now also I repeat the same thing. Diet counseling is time consuming. You have to spend time with the patient so that the patient really understands to implement. So we need to have patience in telling point by point. Everything has, the same recipe can be made more nutritious for the diabetics, but it can be made healthier also. So you have to spend time in telling them how to prepare and what are the ingredients to add instead of, like soup, for example. They can have soup, but instead of adding corn flour, I tell them you add oats to it to thicken it. So this is like a complex carbohydrate. They have this thickened soup, and then it's also like, preventing, or it's a fluid. So this is how you have to make combinations which they will like. So that is, you have to be a little innovative, little patient, spend time with them.
Ma'am, last question to you. This question comes from Praneeth. All of his patients want to eat halim. Is it allowed? What do you tell the patients about halim?
Yes, it is allowed, because halim is something that it's actually less oil is one thing that I have to tell them, but the taste of halim comes with more oil, not necessary. At home, I do make halim during Ramzan time. I do have friends who help me out. It is whole wheat and the fleshy food. Let it be chicken or mutton or whatever, but chicken is more preferred than mutton because it's red meat and a higher risk than chicken. But it is about grounding whole wheat, so it's really good. You can have, but then portion control is something that we have to teach them. Oil control is something that we have to tell them that, see, you have something, but in a controlled environment. So that's how.
Perfect.
Patient won't come back to us if we restrict everything.
Right.
We have to give them everything, but in moderation.
Right. Thank you so much, Dr. Radha. I'm going to go down my list and we'll go a little bit more clinical in our discussion. We heard from a dietetics expert and from endocrinologist. We'll get back to the clinical side of it. And I reiterate the clinical case that we have. It's a 60-year-old female with diabetes, MI recovered, and CKD planning to fast. Creatinine is 2.2 and on insulin. So we'll go back to clinical discussion a little bit. I have Dr. Ali with us. Dr. Ali is a cardiologist. Dr. Ali, if you could please unmute yourself, and we'll go back to the clinical question. How comfortable you feel these kind of patients fasting? What are the things that you look into? If present, you tell them absolutely no for fasting, and the instructions that you give, the clinical instructions, medication adjustments that you do to your patients. Dr. Ali, if you could unmute yourself and share your thoughts. Dr. Ali, please unmute yourself and share your thoughts. We are not able to hear you. And while you do that, let me go on to other attendees. Looks like there may be some problem with your mic. Let us see. We have got Dr. Hari Kiran here. Dr. Hari Kiran, would you be able to unmute yourself and share your thoughts about the clinical case that we are discussing? Dr. Hari Kiran is also a cardiologist. Yes, sir, please go ahead.
Sir, sorry to answer, sir. I'm just into the meet. I'm not at all fully aware regarding the discussion prior. I'm just 5 minutes into the meet. So
okay, so we'll get back to you, Dr. Hari, because we'll have other people share their thought and you will get a sense of what we are discussing. We'll get back to you.
Yeah, thank you.
I'm muting you. Okay, Dr. Praveen, you heard our discussion so far, and I hope you got the clinical case as well. If you could unmute yourself and share your thoughts about this particular case.
Good evening, sir. Regarding this case, if the patient will come regarding the opinion of me, the first thing I would be seeing is her sugar levels in the last 2 weeks, and then I would be adjusting the dosage of the insulin. Probably I will be keeping a basal insulin rather than that of the 2 doses of insulin. And if she is on any oral hypoglycemic agents, I would skip off using them. If it is metformin, would be fine to take her before the initiation of her fasting. Otherwise, if it is sulfonylureas, I would not be asking her to take because of the risk of the hypoglycemia and all that. And if she is on any of the other cardiac drugs which would be related to her daily activity, then I would curtail them down based upon the activity she will be doing during her fasting. Say, for example, if she is all through the day active and she is on the beta blockers, I would not advise her beta blockers if she is during her fasting, if she stays just at the home rather than her usual routine activities. And coming to the nitrates, sir, which because she underwent primary PCI, and if she is on nitrates, I would keep her on the long-acting nitrate. Again, probably the isosorbide mononitrate rather than that of the usual nitrates which we use. And if the patient is on any diuretics, I would stop using the diuretics, sir. And regarding the diets, there were a lot of inputs from the dietitians, but before the start of the lecture, I would advise them not to take the juices which would be fluctuating her blood sugars. And the other thing is not to take, usually what they will be doing is they will be consuming a lot of salty food so that they can be active all through the day. I would advise them not to take that. And regarding the Halim also, I have no idea, sir. And after the opinion of the dietitian, we came to know that they can have the Halim.
Thank you so much, Praveen. We are going to move ahead with other attendees. Let me ask Dr. Shankar's opinion. Dr. Shankar is a physician who had been a regular attendee for our huddle. Dr. Shankar, you heard all of us kind of chiming in our own thought process. Your suggestions to this patient.
Good evening to all. First of all, happy Telugu New Year to all, and Eid Mubarak also to our Muslim friends. This is quite interesting and complicated and a complex case. Patient is a 60 years old lady with 10 years of duration of diabetes and recent myocardial infarction, and underwent primary PCI. And now her serum creatinine is 2.2. It comes to stage 4 CKD. So her EGFR is 24 ml per minute. So first of all, whenever a patient like this insists, though there are religious sanctions are there, they can get exempted from fasting also. But because of their firm belief in their religion, so they may insist for fasting. When they insist for to observe fasting, the onus lies with the primary care physician to observe the fast smoother, safer, and effectively to complete her fasting. So the burden lies with the physician, primary care physician especially. So before whenever the patient wants to go for fasting, I advise them to come to my clinic at least 1 to 2 months before Ramadan, so that I will check up meticulously whether she is fit for fasting or not. Because if there is a poor glycemic control is there, then recurrent episodes of hypoglycemia, if there is any history of ketoacidosis within the past 3 months before Ramadan. So all these things we will ask. If the patient has got any acute illness and any intense labor and all. In the year, this patient has got advanced macrovascular complications are there, and a renal disease stage 4. So the renal disease on dialysis, we don't advise fasting. So here she comes under a moderate risk because she is on oral drugs and as well as insulin and CKD4, and I think she might be fairly controlled with oral drugs and insulin. So if she insists on fasting, I have to take the burden, responsibility to see that her fasting is smoother and safer. So here, if the patient is on glimepiride, this is a long-acting second generation sulfonylureas. Actually, we during Ramadan, sorry, during Ramadan, if the patient there is no other way to start sulfonylureas, we give short-acting sulfonylureas are there, like glipizide, 2.5 or 5 milligrams glipizide can be given even twice daily also. So instead of glimepiride, we can switch on to short-acting glipizide. Suppose if the patient insists on glimepiride because it suits me well, then the glimepiride dose in the morning, that pre-dawn meal, that is known as suhoor, where we make it half. This patient is taking 1 milligrams BD, so we make 0.5 milligrams in the pre-dawn meal. Then 1 milligram is usually at the iftar or the sunset meal. And a teneligliptin, she is taking teneligliptin. There is no robust CV data regarding the teneligliptin. Though it can be given safely in renal patients, but there is some evidence that QT prolongation will be there with the teneligliptin. I don't give teneligliptin in this case, though she is already a cardiovascular disease patient. So I change it to linagliptin in this case. Linagliptin is safer. It is recently in Carolina and Carmelina trials, it is shown that it is non-inferior to sulfonylureas also, and it can be safely given in renal patients. And cardiorenal benefits are there with the teneligliptin, this linagliptin. So I change this patient onto short-acting sulfonylureas like glipizide, low dose, preferably 2.5 milligrams twice daily. And instead of teneligliptin, I switch on to linagliptin of 5 milligrams OD. And regarding the insulin, she is on premix insulin. I think I assume that her blood sugars are under very good control. So she is on premix insulin, Mixtard, morning 22 and evening 16. So the dictum is during Ramadan, the previous pre-Ramadan dosage of in the morning should be shifted to iftar, sunset meal. And the previous evening dose has to be shifted to morning dose, but at the same time, it should be halved. She is evening dose is 16, so she has to take 8 units in the morning before dawn. So, and there's 22 units of premixed insulin can be taken in the evening at the time of iftar. This is regarding the assuming that her blood sugars are under very good control with the SMBG, self-monitoring of the blood glucose levels, if she does the regularly. And as a dietitian and as an endocrinologist, they have opened that this carb counting and correctional dosages, this is a little cumbersome, but the primary care physician or the endocrinologist, has to take a lot of responsibility to see that she is euglycemic throughout this during Ramadan period. And one more regarding the dietary advices, they have given very good advices. We here in my place, there is no dietitian. I am the whole and soul to look after them. So I advise them to take a low calorie diet with the low fat and the low carb, low carbohydrate diet, and advise them to take a whole wheat bread, semolina, the semia, the vegetables, beans, and the fruits should be encouraged. And one more thing, this during Ramadan, we get hypoglycemia, hyperglycemia, dehydration, ketoacidosis, the thrombosis, so many complications will be there during Ramadan in diabetic patients. So to avoid dehydration, I ask them to drink sufficient water, even coconut water also, between iftar and sleep. So during that time only, they can be encouraged to take water. And one more thing, I tell them, pre-dawn meal, the suhoor, should be taken as late as possible. For example, if they want to start, for example, the siren will come and they will start fasting. So just before that, as late as possible, before the start of the daily fast, this pre-dawn meal can be postponed, so that at least it covers the prolonged fasting of more than 14 hours. They will fast, they don't take food and water. So I advise them to take a pre-dawn meal as late as possible. So these are my dietary advices. This is my medication things. I will be happy if I am enlightened more with this Huddle. Thank you, one and all.
Perfect, sir. Thank you so much. Whatever you spoke was very practical, very applicable to the patient subset that we have. We're going to move forward. I will request Dr. Somaraju to suggest his opinion. And sir, I have a particular question for you. While you share your thoughts about this particular case that we are discussing, patients who are on warfarin and for whom we are maintaining a higher INR for whatever reason, be it valve disease or atrial fibrillation or whatnot, any particular advice that you give to these patients, or you make any changes or modifications to that, along with the routine cardiac patient that we are talking about? Somaraju, sir.
Anoop, thank you very much. It was an extremely interesting discussion, but I'll take a completely different point of view. This patient has a coronary artery disease. This patient has diabetes. This patient has CKD. So all comorbidities, and also 60 years plus, and also a housewife. Considering all this, I would say something like human life is the most important resource on earth. It exceeds even the importance of religiosity. And the patients that I have seen And I have been seeing for some more than 40 years now, 99.9% of them, when you tell them you have a difficulty during this time, it will be difficult to maintain your cardiovascular problem, kidney problem, and also say diabetes. Don't do fasting, avoid it. They will be too glad to know that. They want to be told to them in front of their families. And that is a psychological issue also involved in it. And having said that, be aware that one of you said twice a day dose requirement of nitrate, long acting. When a patient of this kind required twice a day dose of nitrate, they are already importantly significant angina they have, they should not be fasting in any manner. They should be excluded. And when somebody says that you eat, you take coconut water, you take fruit juice, you also take high protein diet in the name of some of the preparations they have, with a CKD of more than 2.5 and cardiovascular other problems they have, hyperkalemia is the most dangerous. The first evidence of hyperkalemia is sudden death. So I'll advise this patient not to fast, and 99.9% of the time, they were too glad to hear that. That's the way I practiced, and I'll continue to practice that way. Thank you.
Sir, your thoughts about warfarin therapy, and because there is a relative dehydration in these patients, is there any modification you do, or you take it as the INR comes around?
Warfarin, I don't think there is a significant change in the experience of what we went through.
And sir, how about physical activity in this particular patient subset? Now, this is a housewife that we are dealing with. But if you have a gentleman who kind of walks around and minds his business, do you restrict their physical activity during the daytime?
No, I don't advise them fasting. I'll tell you very clearly.
You don't advise them fasting. Perfect. I think that
Absolute. That is absolute.
you are
Human life, again, to tell all of you, human life is the most important resource on earth. Religiosity comes next.
I think, sir, you are absolutely wide and clear, loud and clear that patients with risk factors. So I chose this particular patient for this reason, because while this patient has got all the comorbidities, she had been doing reasonably well. And I think this is where a few of us, we kind of make our point either ways. What you said is pretty clear, that this patient has enough of risk factors and comorbidities that things can go wrong, and most likely they will go wrong, and it is advisable not to fast. On the other hand, we heard from other colleagues who are of this opinion that even when they have these comorbidities, because they have been nicely controlled, one can take a chance. And both the school of thoughts, the points are well taken. And that is one of the reasons why I brought up this particular case.
The
Yes, sir.
danger of hypoglycemia will be in such a patient with coronary artery disease will be sudden death.
Yeah. I hear you, sir. I absolutely hear you. I absolutely hear you. And I'm trying to justify the rationale of why I chose this particular case for the very simple reason that the decision making between a setup, a risk factor, a comorbidity setup, plus where things are very nicely controlled. So should we take that nicely control into account and give patients a chance, understanding that their psychological well-being is equally important?
Anoop, I have something here.
Yes, sir.
Added to all this, we have the COVID times.
Yes,
Most of us who are talking here won't even be available on telephone.
Yes.
Hospitals are not available also.
Yes, absolutely. I think that you make your point. I concur. You make a very solid point, and that is the whole rationale of us discussing and trying to understand how we make decisions. And your points are well taken. That now we are talking about COVID situation. Now we are talking about situation where in case if they do require help, help may not be that readily available as what it would have been 2 years ago. Vinda, if you are there, I have one question for you. Patients who are on SGLT2 inhibitors, when they fast for Ramadan, is it okay to continue? Modification, no modification? How do you handle? Not this case, creatinine 2.2, she's not on SGLT2, but those patients who are on.
So with SGLT2 inhibitors, I would make sure it's not a new medication initiation. So if the patients have been doing relatively well, like they've been on this drug for a few months before Ramadan starts, I am, I'll definitely evaluate, is that patient a 60 plus person at a risk of, postural hypotension, using any other like, diuretics or, risk for dehydration has to be taken into account during the daytime. So if I'm feeling a little bit uncomfortable, like, with this all background history, like they're elderly, frail people, could fall, get dehydrated, I usually will stop SGLT2 inhibitor. And, we all understand that, SGLT2 inhibitors have had these documented reports of DKA, diabetic ketoacidosis. So I worry about like this starvation ketosis and everything too. So, like if for patients, like I'm okay, younger patients doing well, then I'll switch their SGLT2 inhibitor to be used in the evening with the iftar meal. So I'll switch their time of taking the medication from morning to evening.
Perfect. Thank you, Vinda. It is 8:02. I open the session for general discussion. If anybody has got any thoughts to share, please unmute yourself. And if anybody has got any questions to ask, you can either type your question in the chat box or you can unmute and ask your question. We will stay on for another maybe a minute or two for anybody to share their thoughts or questions before we close. And while you gather your thoughts, just to break the silence, I'll invite one more opinion. I have Dr. Srinivas here with me. He is a cardiologist at Banjara. A lot of you know him. Dr. Srinivas, do you have anything to add about today's discussion that we are having?
The same thing, Dr. Anoop, what Dr. Somraju sir was saying. Definitely, I would say no to fasting in this kind of a patient. That too, fasting for a period of 1 month, creatinine being high, 60-year-old, definitely no. Today itself, I had a patient in the OP, and I managed to convince her not to go on fasting. So, yes, all of us, I think we should put in more time to convince the patient not to go on fasting. I'm sure a lot of patients will listen to this.
Right, and I think that was the decision making that we were talking about in terms of whether patient should go on fast or not, what should be our professional opinion. And also the idea of discussion is those patients who do want to go to fast, how do we facilitate that fasting? And I think a lot of our discussion was geared towards facilitating that fasting, understanding that it may not be the most ideal thing to do in this kind of patient subset. But I think that what we shared was a lot of thought process in terms of how we make decisions in terms of either oral drugs or insulin or their dietary modifications and whatnot. And truly speaking, most of the patients that we are going to get in our clinic may not be as complicated as the one that I brought up for today's discussion. But I think that from today's discussion, we can use these tips and tricks for those patients who are less complicated than this, in whom we don't have reservations going against fasting, and there we can use today's discussion to also facilitate our decision making. I'm still holding on for a few more seconds if anybody has got any thoughts or questions or comments. And if not, then we will wind up today's session. Praneeth, your closing comments summarizing what we discussed today before I end up the session.
Yeah, definitely an interesting discussion that we had. A lot of take-homes. As you rightly said, the decision to fast is probably individual, and it has a lot of responsibility from the physician or the caretaker also to facilitate the decision of the fasting, taking into consideration the health issues that the patient has. Probably spend some time and explain the patient about his clinical condition, about the risks of associated of going to fast, and once the decision is being taken, respect the decision of whether to fast or not to fast. And as you were saying, if the decision is to fast, then how can we make it safe and facilitate that process of fasting from the tips which has been suggested into avoiding large portion of meals or avoiding high carbohydrate diet, high glycemic foods and whatnot, and then chart up and as mentioned by the dietitian as well, spending a lot of time understanding about their patterns and hopefully come to one conclusion where things can be smoother, where it's kind of a win-win situation both to the patient and the caretaker or the physician. That's what I could take from this.
I have one question for the attendees, if anybody could share their thoughts into this. So Ramadan fasting is a global phenomenon. It is something that a big portion of our society does it. And a few of them do have medical risk factors. I wonder if there are community support groups which are there in individual cities or individual societies or communities where patients can share their own thought process and share experiences on a more scientific ground rather than on more beliefs or religious ground. Do we know of any such support group that we have, either virtual or physical, where people can share their thoughts in terms of how they manage their fasting with heart disease or with like, you know, how Alcohol Anonymous and those kind of things are there in Western world? Does anybody know if we have got any such community support group?
Anoop, there is one guideline published by Diabetic Association, and it is worthwhile going through that during Ramadan.
Thank you, sir. Any other ideas? Anybody knows if there is any initiative by any organization, if there is anything that patients can access to, which is obviously not driven by doctors. When I say support groups, they are mostly community support groups where there are thought leaders in that particular field who are able to discuss with the patients. If nobody can come up with right now, I would request if.
Anoop, I just want to say one thing.
Yes, sir.
While I say in this patient, I talk negatively about advising fasting. Fasting is an extremely important component of healthy life outside Ramadan. I'll leave it at that.
Right. Thank you, sir. There is a complete science behind that, and of course, hopefully, in fact, you gave me a hint. Maybe next time or in the future, I will talk about the science behind fasting in one of the huddle session. I think it will be a good discussion, not related to Ramadan, but as a general, the science behind fasting and how it relates to the health. But what I was requesting is, if any of the attendee, if they do find out any kind of support group which help.
Hello.
Yeah,
Sir.
yeah, Neha, you have something to add? Yeah.
Yes, sir. Actually, I want to share this, sir. So there is this thing called International Diabetes Federation. So recently they have collaborated with Diabetes and Ramadan, and they have issued certain guidelines based on clinical evidences to help healthcare professionals to support their approach to safely guide people or patients with diabetes to fast in this holy month. So as per these guidelines, this International Diabetes Federation, they have classified diabetic patients into 3 different groups according to the risk that fasting would impose, like patients with frequent hypoglycemic episode, frequent hyperglycemia episodes, and effect of certain medications on body sugar level. So it's a good write-up, sir. You can if you can go through this. They have even have research ongoing on this, sir.
Perfect. Thank you, Neha, for sharing that. If you don't mind offline sharing that link to me, either WhatsApp or email, and I'll share it with the attendees here. And if, sorry.
Definitely, sir, I'll share it.
Yeah, thank you. And if any one of you do find any community support group which are in place, maybe there is something in your community, maybe there is something in your city. If you have something like that, please share that with me as well. I'd be interested in learning about it and sharing it with my attendees as well. Having said that, it is 8:11. I'll close the session. I thank each one of you for participating. As I said, we have been doing this every Wednesday, and next Wednesday also will come up at 7 p.m. as well. I'm inviting topics that we should be discussing on these forums. So if there is something that you think we should discuss in a casual format like this, please reach out to me and I'll be very happily incorporating in our discussion. Thank you all for your time and participation. Good night, and we'll see you next Wednesday.